So a very good morning to you all once again. I, Dr. Poonam Joshi, welcome you all for our ACTREC Head Neck academic classes. Our today's speaker is Dr. Burhanuddin. Dr. Burhan is assistant professor in Department of Head Neck Surgery at Homi Baba Cancer and Research Hospital, Muzaffarpur, Bihar. He is not only an excellent surgeon, he has been actually the main contributor in head neck department in establishing the Muzaffarpur unit of the TMC. He is going to speak on the topic, the prognostic indicators in oral cancer surgery. With this, I welcome you, Burhan. Please go ahead with your presentation.
Thank you for that warm introduction, ma'am. It was very kind of you, ma'am. Thank you for that. And I will quickly start with the presentation. So I'll try and share my presentation, my slides.
So,
yes.
yes, you can share now.
Is my screen visible?
Yeah, it is visible. Yeah.
Okay. Is it changing? Is it?
Yeah. Please go ahead.
Okay. Yeah. So good morning and welcome everyone and thank you, ma'am, for the opportunity. Basically, we before we start on discussing on the prognostic indicators in nodal cancer surgery, we need to understand that treatment of oral cancer or largely head neck cancer, when it is confined to surgery at times, but it is not only restricted to surgery, and it involves multidisciplinary team management, deciding on when to escalate, when to de-escalate, when to choose, what to choose, and the entire the entire management protocol and guidelines which we all follow. So now, before just to build a little bit of a background, the agenda would be, we would be limiting in this next 45 minutes, we would be limiting ourselves to squamous cell carcinoma. I would not be talking much about the patient risk factors because that would be going too much detailed into multiple patient risk factors, and some of them are one of the most significant and they've been time and tested, like performance status. And not that they are not important. Coming on to post-surgical risk factors, those are again factors which tell us something about the tumor, and they are very important for our understanding. And then a little bit about some emerging concepts about machine learning and the way forward. One very interesting, Dr. Blake Caddy passed away last year. Okay, and he was the chief of surgery and surgical oncology at Harvard, and he made this famous presidential address in which he stated that in the world of surgical oncology, biology is the king, selection is the queen, and technical maneuvers or whatever we do extra or less or more are sometimes they work. Okay, occasionally the prince and princess try to usurp the throne. They almost always fail to overcome the powerful forces of the king and queen. So we now quickly go on to our first aspect, that is the patient factors. In patient factors, basically, we are looking at the age, the frailty, the performance status. The performance status is paramount. And if you see all the studies, we can pick out any study. And once we do a performance stage, perform 2, 3, and you compare it with 0, 1, we definitely find difference in the overall survival. So patient factors are important. Uh, More so the performance status, the frailty, the geriatric assessment, uh, in places like the peripheries or the semi-urban or the rural areas, it's important to not only know the chronological age, but the biological age of the patient as well, the occupation of the patient, whether the patient is going to complete the treatment, whether we are being the entire treatment with the way which we have to offer, whether the patient is going to complete that treatment, lifestyle, smoking, drinking, tobacco, abstinence, whether the patient has already reformed or not, are paramount. Of course, other socioeconomic consideration, and there can be a casual relationship with all of these, okay, but actual causation, it is difficult to find the actual causation in these qualitative factors. So coming on to now the tumor related factors, and largely post surgery, we are dealing, when we deal with the tumor size basically and the tumor dimension. Now we know that tumor is not spherical. If tumor is not spherical, then why do we just depend on the maximum dimension or the diameter? Because it's not like a ball or it's not like a sphere. But since almost like 8 decades now, it's been almost 7 to 8 decades now since staging has been incorporated, and it has stood its time, and it has been proved to be of prognostic significance and predictor of not only the extent of disease, the local disease or the regional disease, like in terms of the lymph node metastasis, but also survival. It still continues to stay in the AJCC. There are some large studies in which they have found, old studies by Magnano, who have found that around with 600 head neck cancer patients and independent prognostic factors of just the tumor size. And but there are some challenges with tumor dimension. Sometimes when we have a varicose lesion or a varicose carcinoma, does size play a role in that? Those are the issues which can be discussed. Probably, those always discussed in a multidisciplinary team management, that what to do for these varicose lesions, or with just a varicose lesion which is quite large but has only few areas and few foci of invasion. So in those areas, do we escalate, de-escalate, and we can have our deliberations on that. Coming on to the next is the tumor differentiation. Again, a very old factor. Okay, right from the 1920s, Borders classification of lip cancers. Then Jacobson tried to see what is happening in the stroma and how the tumor is spreading. Got onto at least 5 criterias and then modified it. Anaroth further modified the Jacobson's. Burney in 1992 came up with Burney and Anaroth both came up with scorings, and then scoring and then giving it as grade 1, grade 2, grade 3, and which is predominantly being followed. So we have degree of keratinization which is there, okay, and the points are given. When there is no keratinization, it's worse, right? Then the number of mitoses, the nuclear pleomorphism, the patterns of invasion. The one on the left is the one which Anaroth proposed, and then slightly modified again by Burney in 1992. And as you can see at the bottom, once we have the score, we grade it as grade 1, grade 2, and grade 3. And tumor differentiation has been shown to have a prognostic role in multiple studies, and it has still stood the test of time as one of the key factors, which gives us not the whole, but at least a glimpse of the kind of tumor we have. Now, one thing very important here is to know whether the tumor is poorly differentiated, and there is good consensus. Also, you may see, once you see all these criteria, it may come to you to to our minds that probably there's so much of heterogeneity or subjectivity to this, and that's why everybody has tried to objectify it. Fine, that could be one aspect, but then there is absolutely no ambiguity about poor differentiation. And when it comes to poor differentiation, this study again conducted partly at ATRAC and Parel at TMH showed that if you see the Kaplan-Meier curves and if you see the overall survival outcomes of early treatment naive node negative oral cancers, just the differentiation was an independent factor, and when it comes to only poorly differentiated, so when you make it dichotomous, that time we found that it was significant, and you can see almost half is the survival, and you can see the Kaplan-Meier splitting quite wide, and it was more associated with tongue and was also associated with perineural invasion, and this were the findings of this study. Coming on to the next is the depth of invasion now. So slightly moving more into pathology, but we will not go into depth of the pathological part, but rather its prognosis and its prognostic significance. So as we know that from the AJCC 8th edition, depth of invasion has been incorporated. Although since Spiro's mid-80s, depth of invasion of tumor thickness has been reported and has been always shown to have increased incidence of lymph node metastasis. If we see a large meta-analysis of around 19 studies by Calderia, 2,400 odd patients, and irrespective of any cutoff, they did find that the odds ratio ranged from 1.69 to 53 times. So that's how wide depth of invasion has been shown to be a prognostic factor. And it not only shows incidence for increased incidence for lymph node metastasis, but also for recurrence and survival. Now, again, it has to be proven in multiple settings. Depth of invasion doesn't come solely. It comes with various other factors. So we need to see it together. And that is why it's important to know more about the entire prognostic landscape of head neck cancer or oral cancer. Again, survival also reduces by up to 51% once we have a depth of invasion greater than 1 centimeter. Here you can see the pictorial diagram is taken from the AJCC manual by Leidit. So basically Leidit homogenized the way a horizon was drawn from the normal mucosa, from the basement membrane of the normal mucosa, and projected. And then a plumb line was drawn till the straight plumb line was drawn. Now, there are some debates regarding whether it has to be a straight plumb line or it has to be a curved plumb line. But I think let's not go into that. But they do follow the criteria of AJCC that when in any ambiguity, it's always better to understage than overstage the tumor in terms of depth of invasion. Again, now coming on to some more aspects of how depth of invasion actually is a prognostic factor. So this large ICOR study with multiple centers, with TMH data also, Indian data also, with Sydney, US data as well, and Princess Margaret data, it was found that when there are between depth of invasion less than 5 millimeters, 5 to 10 millimeters, and more than 10 millimeters, if you can see the 4 risk hazard Kaplan-Meier curves, you find that when there are the C1, when there are no adverse factors, there was hardly any difference in the risk. So you can see 8%, 6%, 10%, 8%, 6%. So that was the difference in the mortality. It was not significant. But when we have other risk factors, Radiotherapy, even when radiotherapy was given in those with no risk factors, there was hardly any difference. But in those as you can see between A and B, when you compare, that when you have additional risk factors along with depth of invasion, maybe radiotherapy or escalating treatment helps. We will not go into the guidelines in this presentation. I would like to just enumerate or describe and give the audience a glimpse of what all factors have been looked at. What is the basic pretext behind escalating or de-escalating treatment in terms of various prognostic factors. So coming on to the next, a big thing in prognostication on the final HPR or even and the biopsy, but it's hardly done on the biopsy. It's only done after the tumor resection, is perineural invasion. We all know that perineural invasion is more microscopic as histopathological classification, and perineural spread is the radiographic representation of the same. We know that it very early studies. Now, PNI has been shown in oral cancer from 20%. Modest figures say that around 20%, 1 in 5 oral cancers will have some form of PNI. It can be reported as high as 52%. There are some inter-observer variations in assessing PNI, but largely it is quite standardized. And at least 33% of the nerve circumference has to be involved by the perineurium and the epineurium. We have Deepa Madam's paper of very large series, around 1,524 patients, in which PNI was found to be an independent risk factor and was associated with poor overall survival as well as disease-specific survival. And in that, it was higher in tongue cases. And when it came to early node-negative cancers, patients with PNI were more likely to develop recurrences and increased mortality with the hazards of around 2.79 and 2.54 for overall survival. So that's very significant. That's more than 2.5 times increased risk. As you can see, the Kaplan-Meier's here from the same paper show that once the PNI is positive, the Kaplan-Meier curves are both in OS as well as disease-free survival in early as well as node-negative cancers. It is segregating. So it is definitely a very important factor. And RT has been found beneficial as well, while when we add radiotherapy, and that is why it is always as taken as an intermediate risk factor in multiple models and multiple guidelines. So important when it comes to PNI is to note whether what is the size of the nerve involved. We can ask our pathologists regarding whether more than 1 millimeter, less than 1 millimeter, whether the PNI was focal, intratumoral, or extratumoral, whether there was something called as a strand-like PNI, okay, which has been described very well in the AJCC handbook, and that's shown to have worse prognosis. Also, there are studies in pancreatic cancer and in which there is a neurotropic substance, and how it's probably the whole understanding of PNI may be different, and it's probably what the tumor secretes and how the nerves are actually, it's the PNI, it's the growth of the nerves and the nerve growth factor which actually causes PNI to occur. And the understanding of the pathophysiology of PNI can tell us more, about how exactly PNI takes place. So PNI, again, very important factor, independent also can be used to escalate treatment, and decision has to be taken by assessing other factors as well. Coming on to lymphovascular emboli or invasion is defined as tumor emboli, which is between the vascular spaces or the endothelial cells. Generally, it has low incidence in oral squamous cell carcinoma, and it is generally associated with other factors. 5% in large series is already 5 to 10, less than 10%. LVE is there, and there's not much of evidence regarding it to be a sole factor. So I didn't find much literature on LVE per se. Coming on to the worst pattern of invasion. Now, this factor is very important, and again, it's not a new factor. Right from Jacobson to Eneroth and Burney, all of them, all these landmark papers which came in pathology in from the 70s till the 90s, they all spoke about some form of this pattern of invasion. But then it was more objectively defined by Brandwin Gansler Weber in 2005 in the original paper, and then which spoke about that, it is the histological risk assessment, and Madam came up with this risk assessment model, which is there in the bottom on the table 9, which is shown. I'll quickly describe that, and then it was validated again. But before we go into what exactly patterns of invasion is, okay, the figure on the top and the cartoon which is there on the top just shows that when you have broad pushing fronts, it's the least aggressive tumor in terms of invasion. Then you have like finger-like projections. Okay, that's 2. Then you have like large clusters which are segregated. Okay, so that's 3. Okay, so now 1, 2, and 3 is largely a cohesive, it's considered cohesive in terms of pathology, like it's a cohesive tumor. The moment you have patterns of invasion, worst pattern of invasions as 4 and 5, you can see that you have small nests of tumor clusters which are less than 15 cells. So you can see small tumor cells around, away from the main tumor. And then in worst pattern 5, you have those clusters which are well away, more than 1 millimeter. And mind you, it's in histology, more than 1 millimeter is now like, it's quite disseminated. So that's why it's the worst pattern 5. And what we have seen, if we compare the hazards, we can see the increasing hazards with WPOI 4 and 5, with the hazards of 2 to hazards of 6. Right? If you see the overall survival in that table. Okay, quick, please please pay attention to the survival data and the hazards which is given. NS is the non-significant, and that's why they have just mentioned NS. But important is that when you take 3 factors together, and they came up with this predictive modeling, that when we take PNI of nerves more than 1 millimeter, worst pattern of invasion, basically 4 or 5, okay, while increasing, giving a score of 1 to 4 and 3 to 5. And then we score, and this model was validated and multiple times, even if there are Indian studies also which have recently even validated these this risk model, and because of this model, this WPOI was incorporated in the AJCC 8th edition. And we have some data even from India, and again from TMC, one of our TMC centers, again a large retrospective study of 322 oral squamous cell carcinoma. And when we compared cohesive, basically worst pattern 1 to 3 versus worst pattern 4 and 5, when combined together, they were found that it was significant. It shows statistical association with on multivariate analysis with PNI and depth of invasion and disease-free survival, as you can see in the Kaplan-Meier curves right adjacent to this text. Coming on to now surgical margins. Yes, again a tumor factor, but there's always a conundrum regarding surgical margins. Every time there's some debate that how much should be our ideal surgical margin, what is the definition, and there is so much of debate going on continuously. But it is everybody would agree in this audience that it is the single most important factor which is modifiable by the surgeon. Uh, so again, just a pictorial description that we need to understand that it's not just the mucosal margin we are looking at. We are looking at the deep and the soft tissue margins, and we are also looking at the osseous margins, like the bony margins, essentially because more than 50% of our resections involve some kind of a bone resection when it comes to oral cancer surgery. Again, traditional data, important landmark paper by Laurie and Strong from MSKCC. They took retrospective data which they had from way back from 1960s till 90s, and they found that there was an 8 percentage point difference in the survival when it comes to involved or positive margins, and they gave the five criteria for margin in terms of margin positivity, pre-malignant changes, carcinoma in situ, and microinvasive nature at the margins. So again, there is almost a reduction in overall survival and doubling of the local recurrence when compared to patients with clear margins. Again, this is a table showing multiple studies and their effect on margins. The study one to note is the largest study by Liao et al. It's a little old study in 2008 study, but 827 patients, and they also did an incremental assessment from margins of 3 to 11 with 1 millimeters, and they found that there was a statistical association with loco-regional control when the margins were less than 7 millimeters. And the survival was 48% versus 65% 5 years when we compared these margins. So margins are important. These are just some figures to tell us, and some data pointers basically to tell us that margins are important, and they have been shown and proven to be one of the significant factors in terms of loco-regional disease recurrence. Again, a landmark paper from the Liverpool group by Sutton and Brown, and where they have, although a little old paper, but then again a clear difference uh, in the outcomes when it comes to positive or close margins, and a 4 times increased risk when it comes to the disease-specific survival with oral squamous cell carcinoma. Important paper. Another interesting paper, actually, this is a recent 2017 paper, but it is an NCDB database study in which they have assessed margins of all solid tumors, basically. And they came up with the 10 most common tumors which have close margins or positive margins. And oral cancer, I was quite surprised that oral cancer is the number one cancer with the highest margin positivity rate. So again, a point to note that why margins are so important and a significant factor in prognostication of oral cancer. Again, the conundrum, just to highlight the conundrum that many surgeons still don't believe that a dysplasia, has any to at the margin is a positive or a close margin, and what to consider that. So, and there was a reckless reliance on frozen section. Up to 99% of the surgeons relied on frozen section, and this was just a survey done from all the yeah. AHNS members. Again, a study from India and from the TMH group again, that when we tried to look at millimeter by millimeter margins, it was found that we should be aiming for a final HPR margin of 5.5, and there was no difference, as you can see in the Kaplan-Meier curves, that unless until the margins are at least 5 millimeters, 5.5 millimeters from 1.5 to 5.5 is the yellow curve, as you can see here. And then the moment it is 5.5, there is a difference. So so 5.5 was found to be adequate, and it slightly increased, the outcome slightly increased till up till 7 millimeters. So again, somewhat pointing out to what Liao et al. Did, and almost comparable results as per the Liao's 2008 paper. This is in contrast to another retrospective study by the MSKCC group, in which the margins were found to, the cutoff was found to be 2.2 millimeters. But it's important that most of the time it was aimed, the surgeries were aimed for adequate margin, gross on table, to aim for 1 centimeter three-dimensionally. And in spite of that, sometimes we end up with close margins. So these are all retrospective data. So this is after the HPR. So for the younger audience in the group, please we do not target these 5.6 millimeter or 5.5 millimeters. It's very difficult to do it in the OR. It's essentially mostly the final HPR data which we are talking about. Coming on to what about, can we have a concept of dynamic margins, in which we decide the margin based on certain risk factors like worst pattern of invasion? And this is an interesting study by Collar, in which again a large retrospective cohort, and they found that even a margin of 1.7 millimeter was adequate when we had these very cohesive tumors with worst pattern of invasion 1, 2, and 3. And the minimum margin was increased to 7.8 millimeters when the worst pattern was 4 and 5. So again a point to think, and an interesting concept of how we plan our resections and its prognostication. Again, a patient, a study from India, again evaluating the depth of invasion and margin. As you can see, the top diagram is a very old paper from basically Japanese studies, in which they used to plan resections based on the depth of invasion using ultrasound or handheld ultrasound. And to validate this, multiple studies have come, and this is a recent study which came up. They did a log, and after doing a log, they came up with this margin to depth ratio. But I just wonder that it's very difficult to know the exact depth of invasion or the worst pattern of invasion preemptively. Only thing what this can do is just tell us about the prognostication. Okay, and doesn't have much application in the at the time of resection per se. So what they said in this paper is that a safe surgical margin can be calculated by multiplying the depth of invasion by a factor of 0.5. Now that's the it can be debated, and we can discuss this in the later half of our interaction. So another important point is the bone and the skin involvement. One thing which I wanted to point out is that the evolving concept of rather medullary involvement versus the bony involvement, just the cortical involvement. We all know sometimes cortical involvement is a function of the tumor or the tumor sitting at the site, and biologically, it is more aggressive when there is marrow involvement. And this has been shown in this systematic review of around 18 studies with a large meta-analysis of 3,700 patients. And if you see the hazards, and you can see the diamonds. The diamonds are the pooled forest plots, pooled hazard ratio, and they're all on the right side of the of unity, showing that that when there is a bone erosion, definitely there is worse outcomes. But then when there is actual medullary invasion, okay, we have worst outcomes, and it's not just the cortical involvement which is there, and that was not found to be, the p-value was not found to be significant. So this has been shown not only in the pathological studies, but also in the histological, radiographic studies, that medullary invasion of the mandible has much worse prognosis in oral squamous cell carcinoma. Coming on to tumor infiltrating lymphocytes, we did talk about that how we were evolving into seeing the tumor microenvironment. And this shows, this table is showing a recent meta-analysis of all the studies with tumor infiltrating lymphocytes studied in the head neck. It is very significant in breast and other cancers. But it is definitely now the time has come, probably to look in head neck cancers as well. And now there is a standardization from the International Immuno-Oncology Biomarker Working Group. So this basically is a body which has now told all the pathologists to have a standard format of reporting TILs. The problem is that it requires IHCs to see for the CD3 plus, CD8 cells and the CD4 cells. And these are basically the lymphocytes in the tumor microenvironment. How are they attacking basically and responding to the tumor? It is basically a immunotherapeutic approach. It helps in that, and it may actually help in de-escalating at times to decide on whether immunotherapy can be given, because that's essentially how immunotherapy works. And it has its own pitfalls of how we morphologically assess, because are we only restricting to the stroma or the intratumoral lymphocytes also? So those are areas of debate which we need not go into in this presentation, but we can discuss later if somebody has any doubts on that. So now, and it's moving towards more automation, because I think with the current automation we can easily count and give a number. It is being told that whatever, if you all have a pathologist in the audience, or who would like to report TIL, ensure that it is reported as a continuous variable. So probably in the next AJCC we can have some recommendation. Coming on to again another factor which is again associated to the tumor microenvironments is the biomarker blood-based neutrophil lymphocyte ratio. Now this has been also extensively studied. Papers have come from all across the world, retrospective, and they have basically essentially looked at these three parameters, three indices. One is the lymphocyte neutrophil to lymphocyte ratio. Then is the lymphocyte to monocyte ratio, and the platelet to lymphocyte ratio. And there were various cutoffs, but somewhere the cutoffs are somewhere around 2.5 to some. The MSKCC study had around 3.5 as the cutoff, 3.5 or 4, if I'm not mistaken. So they use these cutoffs to actually define. So basically, we get a continuous variable, and then we do a AUC and try to put a plot a curve so that we get a cutoff. And it has definitely shown to be a poor prognostic factor. When we have less lymphocytes in the tumor microenvironment, these tumors tend to do worse. And they've also checked in this recent paper that what happens to the tumor, the neutrophil lymphocyte ratio after giving immunotherapy. And they did find that when there is reduction, and if the neutrophil lymphocyte ratio continues to remain high above 4 or 5, the patients do worse. And again, using it as a prognostic tool. So there are no standard cutoffs, and its role is mostly in post-therapy prognostication. But yes, multiple studies are available. Coming on to another thing which is there important, although there is no consensus regarding PDL1 scoring. But yes, if we are looking at adding in any protocol setting or in terms of compassionate grounds, when immunotherapy or any form of immunotherapy has to be added, a PDL1 scoring is done based on immunohistochemistry. Now, it's important that we are aware as surgeons about what this tumor proportion score and the combined positive score is. Okay, so basically, the number of PDL1 positive tumor cells on the upon the total number of viable tumor cells into 100 will give us the TPS score. And the combined, the CPS score, which is actually more used by our medical oncology colleagues, is the number of the tumor cells, the lymphocytes, and the macrophages. Okay, so basically what happens is that tumor cells upregulate PDL1 on the surface of the tumor cells, and binding of the PD1 on the T cells to promote an exhausted immune signature in the tumor microenvironment. So that's how the tumor tricks the body's innate immunity. And we need to look at that objectively before we subject the patient to some form of immunotherapy. And using that pretext, these things have come up. And so there are no actual cutoffs that what should be the CPS score. Some say more than 1, some say more than 50%, 20%. It varies. There are multiple studies. There's no consensus yet. There is it is now, but the calculation is pretty much standardized. And and generally, PDL1 is underestimated in biopsies, okay, as compared to the resection specimens, because it's not the complete tumor or the representative tumor. So that's one point to be noted here. So this is this emergency. I'll just end this call 1 second. Sorry, extremely sorry for this. Coming on to the nodal factors now. Okay, we know that the extent of nodal dissection and is important, and some form of either assessment of the neck is done either by a sentinel lymph node biopsy or elective neck dissection or a comprehensive neck dissection. There can be debate regarding the extent of lymph node clearance when there is pathologically, clinically node positive disease, whether 4 and 5 to include, whether only 4 to include. We can debate on that, but comprehensive neck dissection is something which is done, and in a node positive disease. Now, a lot of interesting data points here that we need to, in a large, increasing the number of lymph nodes examined has shown to improve the outcomes. Okay, in this large, around 14,000 patients of NCDB database, when they just looked each number, increasing the number each number wise, and the curve plateaued at 35 lymph nodes. So it is a collective responsibility of the surgeons to fish out the nodes correctly and do a complete neck dissection, as well as the pathologist to examine as many as possible. Okay, and in our pathology friends also use multiple methods and have evolved to better report the number of lymph nodes harvested. Again, minimum 18 nodes are to be harvested, and as per this paper by Ibrahimi et al. Again, in which they came up with this minimum number of at least 18 nodes, which have shown to be found to be associated with reduced overall survival with a hazards risk of around 1.67. So that's another important point, that first of all, we need to have a good assessment of the nodes. Now, coming on to what happens, sorry, what happens to the lymph node yield, and again, continuing on that as you can see in that Ibrahimi paper, that there's significant difference.
Like the other one. No, I've not seen it.
Difference in the nodal yield, difference in the outcomes when the nodal yield is less than 18 versus more than 18. And when they took patients from across the globe, basically in this meta-analysis with data from Brazil, from Taiwan, MSKCC, and as you can see, when for everyone, for all the centers, the hazard, the forest plot is showing that the hazards were worse when the lymph nodes were less than 18 when they were harvested. And two prospective RTOG studies, if we take the pool data of that, both RTOG 9501 and RTOG 00234, they also found the same finding, that it was rather the lymph node yield than the LNR, which is also like in this paper by Sear, in which they looked at the Sear data by Roberts et al. Number of positive nodes is superior to the lymph node ratio. Okay, lymph node positive ratio. Okay, and they did this analysis, and here you can see that there was better hazards discrimination seen when we had increased nodes which were positive. Now, coming on to these nodes, how many nodes actually turn out positive? So if there's one node, two nodes, so if we see that if we there is a treatment escalation can be suggested to improve outcomes up till 5 nodes, and then it plateaus. So then that there was not found, then it was so worse basically that it was not found to have any escalation of treatment, didn't find any fruitful advantage in this analysis. So the increased number of nodes which are positive have a worse outcome, and that is important in our understanding of the pathological nodal description. Again, three prospective, sorry for the spelling, three prospective RCTs. Again, this paper by Lu et al. And the previous paper by Daniel Triflati, both showing that that on multivariate analysis, the overall survival, the disease-free survival decreased with each positive lymph node without a plateau, and it was most pronounced up to 5 lymph nodes, and showing a hazards of 1.21 per lymph node, which was positive. And this is again a very important paper, that how increased number of lymph nodes decreases the survival function, and areas and after not only increases the risk for local recurrence but also distant metastasis. So after 5 node distant metastasis risk continues to increase beyond 5 lymph nodes are positive. So that was again one finding. So probably escalating treatment. So even if there is no ENE or the traditional factors which we'll be discussing further about ENE, but when we can escalate treatment when it comes to the number of nodes being positive, the study. Again, coming on to ENE, we can classify ENE as per micro or macro ENE when it is within 2 millimeters of the capsule. In this, it is showing that it has gone beyond the capsule 2.5 millimeters, so it is a macro ENE. Currently, only macro ENE upstages the AJCC, but there are various different models being proposed after the AJCC 8th edition to probably modify AJCC, and in the next AJCC, we may have even micro ENE as one of our factors upstaging the staging in oral cancer. So, so this is another paper, recent, hot off the press, in which they say that actually the P3 pathological N3A is actually very rare. Yes, that is exactly true. And when they took 1,400 patients from Princess Margaret, from MSKCC, Sydney, and North Carolina, they stratified based on the extent of ENE. And in the top in the table on the top, we can see that there are various N classifications which have been proposed, like and the C indexes with the hazard discrimination which has been seen. So what they propose is that one is that we, by now in our presentation also, we have established this beyond doubt that the number of nodes which are positive makes the matters worse. So it is important to not only document the number of nodes which are positive, but also to see if there is micro or macro ENE, and do away with probably the N2C, because essentially it's the function of multiple nodes which actually come positive. And probably this is another proposed, so basically a regression analysis in which they propose that if there is multiple nodes with micro ENE, then it becomes N3A, and N3B is only when there are multiple nodes or nodes more than 3 centimeters with major ENE. So that's the change which has been proposed. So coming on to the next is my screen being shared?
Yes, it is, Burhan. I think,
Yeah, sorry.
that's okay.
Yeah, is it being shared, ma'am? Sorry,
Yes,
I think
yes,
I
we
moved
can see, Burhan.
ribbon.
Yeah.
Yeah, sorry, ma'am.
Can,
Yeah, so again, another, it's a very recent paper and an interesting paper of how we can better prognosticate our patients based on the number of lymph nodes which come positive. So again, traditional, this is a picked up slide again, because we all know the importance of margin positivity and ENE, and how chemotherapy is added. Concurrent chemotherapy is added and improved outcomes by these two landmark papers by Bernier Cooper and their combined analysis of the URTC 2931 and the RTOG 9501. So multiple factors were taken. So what actually were found to be really significant was in the combined analysis were the margin positivity and the extranodal extension. But as we have seen, we have evolved from this 20 years in last 20 years in identifying further factors which are other pointers, which can be pointers to escalate or de-escalate treatment and prognosticate our patients. These are data points in which there was significant improvement in the overall survival, up to 13 percentage points. Again, to continue on the importance of escalating treatment, we have a landmark paper from India by Sarbani ma'am, phenomenal study of 900 single center 1:1:1 randomization, unheard of in oral cancer, with treatment intensification in terms of radiotherapy as well as treatment intensification in terms of chemotherapy, adding concurrent chemotherapy. And they did show that in tumors with high risk features, when there are increased nodal burden and with ENE, there was improved outcomes. Otherwise, there was no improved outcome. But when in a particular subgroup, the OCAT study did show that there was advantage of adding concurrent chemotherapy or even doing accelerated hypofractionation. Hyperfractionation. Coming on to again another paper by Triflati. It was again an NCDB database of a large cohort of patients, and they found that it was they talked about other factors going beyond just a positive margin and extracapsular extension in evaluating the impact of postoperative chemoradiotherapy. And here, as you can see, that when it comes to multiple nodes from 2 to 4, also they found that the curves were slightly different. So you can probably see that the curves are separating, and they are separating all together. Wait till the end. This was more marked when the nodes were more than 5 nodes were involved. This again is a pointer that there can be a subgroup of patients in which we can perhaps escalate treatment in terms of the number of nodes when they come positive. Coming on to the next slide is when we have multiple of these factors, we then try to put them all across, use logistic regression to come up with multiple nomograms. Now, this is a recent nomogram by 5 Asian hospitals, TMC Kolkata, Amrita from Singapore, and I think other 1 or 2 centers, and they came up according to they came up with a nomogram for each intermediate, low, and high risk oral cancer. And what they found is for low risk cancers, PNI and pathological N node was found to be significant in their nomogram. When it came to intermediate risk group, it was basically the bone invasion. And when it was coming into the high risk group, as per the NCCN, it was mainly the margins, the PNI, depth of invasion, histopathological differentiation, and the P stage. So basically, you just plot each factor on this a linear scale, and then come up with a score, and then there is a corresponding scale which shows the survival and which projects the survival and predicts the survival. This largely uses regression statistics to derive. They have a training and a validation set. There has to be a certain amount of concordance, a C index, and a lot of statistics basically to tell us that how we can predict. But so we have a TMH group also. We have our data in which we also tried to do the same thing. And specifically, again, we cannot take everything together because then it becomes a potpourri of everything. So we have to restrict ourselves to certain stage or a site. And in this, we specifically looked at T4 buccal cancers. And we found that the grade, the tumor invasion, the lymph node involvement, and the bone infiltration were found to be significant on multivariate. And then we projected them on a nomogram and came up with this scoring nomogram. In this, where you can see that depending on these factors in a T4 buccal cancer, once we grade, we get a score. And we found that there was significant difference when the score was about 13. And 13.5 was found to be cut off, and it had a very good C index. So this nomogram's glory would be the concordance index, that is very high C index. So this is how it was done, and it had its own training and validation set. So again, a pointer that these methods can be used. Not only we have to restrict ourselves to TNM, we have to think beyond just TNM, pathological factors, other factors as well. Again, just to take this forward now, we have to understand that neural networks work differently when it comes to traditional regression statistics. So just like how neurons work in our brain, the neural networks take each process, each data separately, and then build up and predict and try to predict the immediate next data set. And that's how they learn. Machine learning happens, and the concept itself is different. It's and multiple machine learning models have been used, deep learning, to predict outcomes. Like in this web-based, they found that there was a good concordance in terms of prognostication when they used depth of invasion, grade, budding, WPOI, loss of heterozygosity, and PNI, gender, age. And when they put it across the neural network model, they were able to generate a valid model according to them. But important is that see, the way it is done is totally challenging the traditional ways we have seen survival. Okay, so the deep learning based survival analysis itself is different, and they rely rather on a random survival forest rather than the traditional forest plots which we use for hazards. So it's a totally different way of looking at statistics. And one thing very important is that they don't fit in the AJCC predictive modeling criteria. So AJCC has a strict predictive modeling criteria. If they're like multiple guidelines saying that if a predictive model has to fulfill certain criteria. So these models do not fit in that, nor do any of the nomograms do. But and that is why they are not adapted by the AJCC. So in certain tumors, in certain other tumors of the body, when they have a better established model, it can be easily adapted. But time is yet to come when we have in oral cancer, we have any kind of a scoring or a predictive model which is going to be incorporated into the AJCC. But I think it is not far. We'll not go too much into the molecular markers, but I would just like to enumerate the various pathways and the molecular markers of those pathways, like the EGFR pathway, the PIK3K, ATK, mTOR pathway, the JAK-STAT pathway, the MET pathway, the beta-catenin pathway, the RAS-RAF pathway. So these are basically pathways which we need to brush up with our molecular understanding of tumor biology. And these are all have been studied in oral cancer. So, and all have at various level multiple mutations, deletions, which are seen and which can be incorporated, and they have shown some prognostic implication. Multiple studies have shown that. But how to translate that into escalating treatment or de-escalating treatment? There are trials underway. And we still cannot, we can at max prognosticate for counseling, but not in terms of treatment intensification or de-intensification. Coming on to what happens at the microbiome level, and there is a tumor microbiome interaction that also has been studied. So they've tried to look at the microbiome on the surface of the tumor, the pathological microbiome inside or at the adjacent normal tissue and inside the tumor as well. And they have come up with significant correlation in terms of certain pathological microbiota like Fusobacterium. We have that study from ATTRAC itself showing that there was in early stage HPV negative tongue cancer. There was significant association with Fusobacterium being notorious actually. And we have multiple other genuses and like the Parvotella, Prophyromonas, and other bacteria which have been studied. And these are basically coming on from now the proteomics and the NGS studies of the tumor microbiome. Coming on to the last on minimal residual disease, that itself has been now picking up concept after colon cancer, the landmark studies in colon cancer, in which they tried to look at the circulating tumor DNA, the cell-free tumor-specific DNA in the blood. Okay, and then to decide on escalating or de-escalating treatment. There is some evidence from our group which did show that there was an increased number of CTCs seen in all stages of early and advanced cancers. And once we have circulating tumors more than around 13, there was increased risk associated with ENE, perineural invasion, and it was all correlating with the other prognostic factors. And when we look at the ctDNA findings also, and these slides are courtesy Kumar sir and Pankaj sir's study, in which they were looking at the ctDNA and the longitudinal assessment of this minimal residual disease, and how after basically head neck cancer, and they did find that these all mutations were seen in the univariate and the multivariate, the TP53, more than 5 mutations. The TF, which is the tumor fraction, what part of the DNA is the tumor DNA and what part is the normal DNA in the cell-free DNA which was extracted in the blood. So those liquid biopsy and liquid biopsy based risk modeling and prediction is also catching pace, and a lot of studies being done in that arena. Here you can see that there's significant difference in the outcomes, again with different with the STAT pathway as we discussed previously. And here you can see the ROC of tumor fraction, basically tumor fraction again showing significant that the tumor DNA versus the total DNA in the cell-free DNA, which was found to be a strong predictor for survival. Similarly, this again showing a cutoff of around 22, tumor fraction cutoff of 22. This is just basically how they have tried to analyze these changes, and at multiple level, at the epigenetic, at the gene level, and at the chromatin level. So trying to conclude as of now, so that we can take a few questions. My take home for this presentation is that there are multiple factors which are important in prognostication after oral cancer surgery, and we need to think beyond histopathology. May be clinically relevant outside a study or a protocol setting. Biology is the king, but it is not an enigma anymore. We are more and more into understanding it better. Of course, needless, having said that, it's a continuous process. Less may be more, but not so for some. So we shouldn't just go by the bandwagon that always go for less, and de-escalation is the only way forward, or escalating is the only way forward. We have to keep our minds open, and very important is the crosstalk between all the stakeholders, right? From the researchers, from the to the caregivers, even the problems what they face in just escalating treatment at times. So everything we have to take understand the entire all the stakeholders, the perspective of all the stakeholders, to decide on prognostication and how we utilize prognostication to tailor our treatments. So thank you, everyone. I would just acknowledge my teachers, and especially Poonam madam, for the opportunity, my colleagues whom I worked here previously, and my juniors here, Dr. Shinjita, Meghna, Soumya Kanti, and all those who are seen and unseen behind all the work which we all do. So thank you. Thank you, ma'am.
Thank you, Burhan, for such a comprehensive lecture. And thank you for such beautiful words as well. Burhan, I would request now you take, there are few questions on the chat box. If you would be, Burhan, hello? Hello?
Hello, ma'am. I'm really sorry I didn't see the chat box because I had just minimized the ribbon.
Yeah, no
Uh,
problem. So first
so
question is role
I
of
will now
tumor
take.
budding. So role of tumor budding in oral squamous cell carcinoma.
Yes. So tumor budding has been shown in multiple studies. It has shown, and it is basically tumor budding and PNI. Both are at times when we go into the depth of it, it is sometimes difficult to ascertain what exactly and where to draw the line between these tumor budding and the worst pattern of invasion and PNI, because then at some point they overlap. So it is definitely a relevant factor, and please document that. But it would consider as a soft indicator. And whenever you are seeing the pathological factors as a whole, please keep tumor budding in mind. And it has been shown to have some significance, both in multivariate analysis as well. So, but it has a lot of overlap. Please understand these factors are pathological factors, and they sometimes do overlap.
And I think, Burhan, we need to have more data before we consider them as, like you rightly said, as an important prognostic factor. So many a times you
Yes.
need to get a lot of data, you need to validate it. Then only it comes into the picture of those important prognostic factors. Still, there is more need to get more data or more information and its role as a negative prognostic factor. But like Burhan said, it is important a factor and has been shown to be associated with local regional recurrences and distant mets as well. But still, there is time to get more data. So there is another question: what should be ideal surgical margin of skin when skin is involved, or any data?
And the and when there is dermal foci, when there is these dermal foci, which are the dermal lymphatics, through the dermal lymphatics, ideal margin in the skin can is difficult to ascertain. But as of now, if you ask me one short answer, it would be still the same, provided you have assessed it well and you are quite sure that it is only as a spread of the local disease into the skin. If you have a florid dermal lymphatic spread, I would rather reassess the tumor in terms of its assessment before embarking on surgery.
Right. How are tumor infiltrating lymphocytes identified?
So what they do is basically they do IHCs, okay, and they mark those lymphocytes like CD3 plus, CD4. All these are IHC. They're standard IHCs now for all these, and then they kind of see that, they calculate a percentage and they report a percentage. So that's a simplified version which I've understood. I'm sure it's a whole science of its own, but it has been now quite standardized since almost now 10 years. It's been standard. Initially it came early in 2014 in breast cancer. So by now, there is as I showed in the presentation, that there's an international immuno-onco consensus for this, that how you should report it and do it. So it can be even automated. So even machines can directly tell you that as well.
So another question: does assessment of worst pattern of invasion in incisional biopsy affect the treatment plan in relation to margins?
Very difficult question. There's some data which is there. I just tried to nudge our minds that, that kind of data is there. But see, essentially it's all very retrospective, 200 odd retrospective data. And we are not quite sure about the exact assessment of WPOI on a small incisional biopsy. So to base our data and decision and margins on that, I think it would be a long shot. So I would urge you all not to do that, and rather write a protocol or do it in a setting in which you can actually, convince your ethics committee and your peers that how you would like to go about this, and then come up, because that would be actually helping further more patients. Okay, and not only restricted to that one particular patient who you feel may benefit by reducing the margin or something.
I think which is the best or the most important independent prognostic factor in head neck cancer?
I don't know. For this, I think I should use what my seniors and Poonam ma'am used to see when she used to see our data. She used to first run an analysis and see if univariate and multivariate with ENE comes positive. Okay, so that's how generally they assess data, and to see how the follow-up or everything was correct and the validity and the credibility of the data was generally assessed with seeing ENE, because I feel ENE is one strong factor which is very significant in terms of outcomes. Ma'am, any other thoughts or
I
something?
completely agree with you, Burhan. I think ENE and the other would be positive margins, which you already
Positive
described in
margins.
detail.
Yes.
So I think these are the two most important independent prognostic factors. I think rest of them, Burhan has beautifully explained about all of them. So these would be the two most important factors where you mostly would need an adjuvant to make to give them adjuvant treatment so that they have better survival, so that you can make a difference. So that would be the way to go. I think there are a lot of questions, Burhan. I think these are two last questions in play. So much of enthusiasm, because it was a great lecture. Prahlad has asked, isn't it difficult to assess WPOI without resection specimen? Yes, it is.
Yes.
And we
Yes,
see
exactly.
Yes, WPOI 3 in incisional biopsy, but other parts of tumor may have 5. You have already answered. Yes, Burhan, would you like to add?
Yeah, ma'am. That's all, ma'am. Yeah.
So I think
Same.
tumor is usually heterogeneous, no? So in everything you will get the heterogeneity also is an important part of tumor. So that's why Burhan said that whenever you have this, when you have the big specimen, naturally you have better findings and more detailed findings. So because tumor is always heterogeneous, even then we are not seeing each and every part of the tumor. So with that, so I think Burhan, great lecture. And I think we all.
Thank you. I may have missed a lot of factors.
I learned relearned so many things actually, and we are really thankful. Great lecture, great lecture, and your service also.
No, ma'am. Thank you, ma'am, for your words. But there are a lot of other factors, and I may have missed a lot of them as well. So it's everybody's trying to find out.
Yeah.
So
I think
let's
patient-related factors are also important. But I think, like Burhan initially only said that because of the paucity of the time, we can't go into that detail because that's entirely a different topic. But those factors, though they are soft indicators, they have to be taken into account.
Yes, ma'am. Yes, exactly. Very true. That patient factor, sometimes and many times most of our decisions are actually based on patient factors. And sometimes we totally neglect a patient factor, and then we do not achieve good outcomes at times. So patient factors are paramount. Again, reiterating what ma'am said. Although it looks very trivial, the ECOG status, but ECOG status is one of the, I feel it's one of the most important factor.
You're right. Yeah. So with this, I conclude today's lecture. Thank you once again. It was a great presentation, Burhan. Thank you so much.
Thank you, ma'am. Thank you, ma'am. Thank you.